presenting surgical anatomy, and after that, acute pancreatitis will be presented by Lalit.
Good afternoon, teachers and seniors. I'll be starting with surgical anatomy of pancreas, and this will be covering with location, physiology, gross anatomy, parts of the pancreas, peritoneal coverings, artery, venous, lymphatic nerve supply, congenital anomalies, along with the embryology and investigations. So
you will get only 10 minutes.
Okay, sir.
Yes.
So location of pancreas, it is elongated accessory digestive gland which lies retroperitoneally. Clinical significance is that because it is a deep-seated structure, so it is rarely injured, but when it is injured, at that time it may be crushed against the vertebral column, producing ductal tears and leakage of the pancreatic secretions. And signs and symptoms are usually associated with pancreas are usually vague abdominal complaints. And now coming to physiology, in pancreas, there's an exocrine secretion and endocrine secretion. Exocrine secretion is the pancreatic fluid from the SNR cells, which enter the duodenum and then through the main and accessory pancreatic ducts, whereas endocrine secretions are the glucagon and insulin from the pancreatic islets that enter the blood. So as we can see this tabular form, the pancreatic exocrine enzymes are mainly they are amylase, protein, endopeptidase, trypsinogens. Usually these are the enzymes which are later converted, like trypsinogen is converted to trypsin, chymotrypsinogen to chymotrypsin, etc. Then pancreatic lipase, phospholipase A2, and cholesterol esterase. Now, then comes pancreatic endocrine enzymes. Usually they are insulin, which is secreted by beta cells, and all of us know that it decreases gluconeogenesis and glycogenolysis, fatty acid breakdown. Then, apart from insulin, other important one is glucagon, which is secreted by the alpha cells, then somatostatin by the delta cells, and pancreatic polypeptide, amylin, and pancreatistatin.
Yes, continue.
Yes, sir. Not able to yeah. This is just a short video, but I don't have enough time. 1 second.
Fast forward the it wherever you feel like.
Sorry.
You see, forget about the video. We don't want to see the video.
Sure, sir. Then gross anatomy, it is soft, elongated, flattened. Length is 4 to 6 inches. Weight is 92 grams. No true capsule is there, and there is covering of only fine connective tissues. Now we comes to parts of the pancreas: head, neck, body, and tail. Now head is the expanded part. As you can see here, this is the head over here, which is embraced in the C-shaped curve of the duodenum. Then it is attached to the medial aspect of the descending and horizontal parts of the duodenum. Now next, these are the relations of the head. Anterior surface is the pylorus and the duodenum, transverse colon, and posteriorly it is the right kidney and renal vessels. Then comes the neck. It is short and overlies the superior mesenteric vessels, which form a groove in the posterior aspect. And the anterior surface is covered by the peritoneum adjacent to the pylorus of the stomach. Now, next we come to the neck part. These are the relations. As you can see, now body continues from the neck to the and lies to the left of the superior mesenteric vessels, and it also passes over the aorta and L2 vertebrae. After body, now comes the tail. It lies anterior to the left kidney, where it is related to the left kidney, and it is related to splenic hilum and the left colic flexure. Then this is the uncinate process. It is projection from the lower part of the head extending upward and to the left, lies posterior to the superior mesenteric artery and the vein, and it lies anterior to the aorta and the inferior vena cava. Now peritoneal coverings. Posteriorly, two layers of the peritoneum diverge on the anterior surface of the head and the body, and anterior layer passes upwards and cover the anterior surface, while the posterior layer downwards and covers the inferior surface. And end of the tail is within the linorhinal ligament, but while the posterior surface is devoid of peritoneum. So the clinical significance is because it is devoid of peritoneum, so this contributes to the high incidence of recurrence of CA pancreas even after the resection. Then arterial supply of the pancreas. In arterial supply of pancreas, mainly, as you can see, pancreatic arteries, they are derived mainly branches of the splenic artery, and mainly the arterial supply is to the anterior and posterior superior pancreaticoduodenal arteries, branches of the gastroduodenal artery, and anterior and posterior inferior pancreaticoduodenal artery, which are branches of the superior mesenteric artery. Then comes the venous drainage, which is from the suprapancreatic portal vein, retropancreatic portal vein, splenic veins, and infrapancreatic superior mesenteric veins. Now, lymphatic drainage, it is divided into 5 main groups, that is superior nodes which drain into the upper half of the head of the pancreas. Then comes the anterior lymphatic drainage to the prepyloric and infrapyloric nodes. Inferior group of nodes drain into the superior mesenteric and periaortic nodes, and then superior pancreaticoduodenal lymph nodes drain into the right periaortic nodes, and splenic nodes which drain into the intercholimesenteric lymph nodes. Again, significance is the absence of the through lymphatics. Carcinoma of pancreas actually spread to other parts of the abdomen. Then pancreatic lymphatic vessels also follow the blood vessels, and most of them end in the pancreaticosplenic nodes that lie along the splenic artery, but some vessels end in the pyloric lymph nodes. Then nerves of the pancreas are derived from the vagus and abdominopelvic
There is lot of noise. Some people have already, they have not. Can you just ask them to just mute their
Please mute your mic. There's some disturbance.
There are some people. There must be a group of students staying together. They are creating a lot of noise. Ask them to mute their microphones.
Mute the microphone.
Continue. Yes, sir. So the nerve supply is through vagus and abdominopelvic flanking nerves, and all this arterial supply, venous supply is important because during the resection of pancreas, usually in Whipple's surgery, and also
Still someone has not muted. Still someone has not muted it. There is a lot of noise.
Kritika, since you are the host, you can mute everybody's mic.
Kritika, you yourself.
ये ललित कर रहा है कि कौन कर रहा है वहाँ ये
सर वो हेलो
यस
गुड आफ्टरनून सर वो शायद अशोक सर के वहाँ से आ रही है
अशोक सर के कहाँ से
मतलब वो सर के माइक से आ रही है आवाज
किसी
वो तो वहाँ पे किसी स्टूडेंट की आ रही है
कोई बात नहीं
अरे डॉक्टर अशोक
जी सर आयु
अरे अपना माइक जरा म्यूट कर दीजिए वहां पर ना इसमें ये आती है हिसिंग साउंड
ओके सर थैंक यू वेरी मच
Thank you, sir.
Continue, Dr.
Sir, applied anatomy is inferior pancreaticoduodenal artery needs to be controlled while dissecting head of pancreas of the superior mesenteric artery during the Whipple's procedure. So we need to be careful. Plus, superior vein drains directly into portal vein just above the neck of the pancreas and is often the larger branch of portal vein, which is divided during the Whipple's procedure. Now comes the embryo.
Is there any diagrammatic representation you are just reading?
Yes, sir.
Vascular supply, lymphatic drainage.
She has
sir,
had so many. These are all diagrams only.
Can you show the pictures?
Sir, which one?
Can you show the pictures?
Sir, arterial supply come in. This is the
Yes.
arterial supply, and the applied is that inferior pancreaticoduodenal artery needs to be controlled while dissecting head of the pancreas. Then the second is inferior pancreatic artery. Then inferior pancreaticoduodenal artery. Again, it has to be. It is a branch of superior mesenteric artery, and again it has to be. It is impossible to dissect head of the pancreas without devascularizing duodenum unless a rim of the pancreas containing pancreaticoduodenal arcade is reserved. So this is the arcade which is formed by anastomosis of many vessels. This is the celiac trunk, and from here this is the gastroduodenal artery. Then this is the proper hepatic artery which is going to supply the liver. Then here is the gastroepiploic artery, and as we can see here,
this is the gastroduodenal artery. This is from the celiac axis. You have three branches. This is the main trunk of the hepatic artery, which divides into hepatic artery proper, and then the gastroduodenal artery, which divides into anterior and posterior.
Yes, sir.
Superior pancreaticoduodenal arteries, and the inferior pancreaticoduodenal arteries come from the superior mesenteric artery. They anastomose together and form a rich plexus of vessels on the anterior and posterior surface of the duodenum. In addition to this pancreas, in addition to that, you have vessels which come from the splenic artery. Okay, continue.
Which one is the main vessel? Which one is the main vessel?
Inferior mesenteric artery is the main vessel.
And is there any arteria magna?
Yes, sir. From here, sir, this artery from this here that artery is formed magna.
This
it
is the
is
splenic
actually
artery.
It is branch of, I think, splenic.
Okay, go ahead.
Then comes the embryology. So as we can see in embryology,
Why you have not started embryology in the beginning?
Sir,
why in the last?
Sir, I wanted to discuss the congenital anomalies, so I added it here. So in embryology, usually there are two, there's a ventral mesentery and the dorsal mesentery, and as we can see here that the pancreas develop from two separate growth buds of tissues, both of which arise from the distal foregut and develops within the mesentery. That is the ventral pancreatic bud and the dorsal pancreatic bud. So here this is the ventral one and this is the dorsal one. Now from the ventral pancreatic bud, which is the smaller one, it branches from the hepatic diverticulum in ventral mesentery and therefore shares duct drainage system with liver, and it forms later on it forms the pancreatic head and the uncinate process. So it will rotate towards the other side to fuse with the dorsal pancreatic this, and the dorsal pancreatic bud which forms in the dorsal mesentery, and it forms the pancreatic neck, body and tail later on. Like you can see here, this is the ventral, this is the dorsal, both of them are fusing and later forming a one pancreas only. Then there are duct system here. So there is this is the main pancreatic duct. So the main pancreatic duct, it begins in the tail of the pancreas and run towards the parenchyma of the duct to the pancreatic head, and there it turns inferiorly and closely related to the bile duct. And most of the time
what is the other name of main pancreatic duct?
Sir, it joins main pancreatic.
Is it duct of Wirsing or duct of Santorini? What is this main pancreatic duct?
The duct of Santorini.
No.
Brisberg. Duct of Brisberg. And the other one is, accessory one is the duct of Santorini. So
this is that duct of Wirsing, and the other one, accessory duct is duct of Santorini. Yes.
So this is the main duct, and this is the accessory pancreatic duct over here, as we can see. So it opens into the duodenum at the summit of the minor duodenal papilla, and usually 60% communicates with the main pancreatic duct. Now these are the smooth muscle sphincters that control the flow of bile.
इसकी clinical significance क्या है इस duct की?
Sir, main pancreatic duct which joins the.
इसकी clinical significance
Yes,
ये
sir.
है कि इसका diameter जो है in the tail it is.
Hello. Hello. Sir, main pancreatic duct joins the CBT to drains into the second part of the duodenum via major duodenal papillae, and it is formed by the duct system of the ventral bud and the dorsal bud, and accessory which drains via minor duodenal papillae. It is formed by the duct system in proximal part of the dorsal bud. And sir, यहाँ पर the smooth muscle sphincters which control the bile, these are the sphincter of the pancreatic duct, then sphincter of bile duct, and sphincter of hepatopancreatic, that is the sphincter of Oddi. Over here, as we can see, this is the sphincter of Oddi, and here flow of bile will be there. Now, after this, I'll just discuss the congenital anomalies. First one is the agenesis, where the pancreas is totally absent, and it is the hemodomain transcript factor IPF1, which is critical in the development of pancreas, and the mutation in the IPF1 gene on chromosome 13q12.1, which has been reported with this agenesis. The second one is annular pancreas. So usually what happens is that as you can see, the two parts, the dorsal and the ventral part should fuse together on one side only, but here it has not properly fused. So annular pancreas, it develops when one portion of the ventral pancreatic primordium becomes fixed. This one is fixed, and while the other portion of the primordium is drawn around the second or third duodenum, and it can be associated with duodenal atresia or stenosis, because this is the duodenum which is going, and it can be stenosed or atresia can be there. Usually it is seen with Down syndrome, and usually there are signs and symptoms of duodenal obstruction, such as gastric distension and vomiting associated with it, and the treatment is duodenostomy. Then ectopic pancreas, usually the sites for ectopia are stomach and duodenum, followed by jejunum, Meckel's diverticulum, and ileum. And if ectopic pancreas is there, it may cause pain from localized inflammation or mucosal bleeding. And the clinical importance is that approximately 2% of the islet cell tumors arise from this ectopic pancreatic tissue. Then is the pancreatic divisum, which is most common, clinically significant, and it is caused by failure of the fetal duct system of the dorsal and pancreatic primordia to fuse. So as you can see here, this is the dorsal, this is the ventral. Both of them have not fused properly, again giving rise to the pancreatic divisum. Lastly, I'll just discuss the investigations that we do usually for pancreatic pathology. So investigations are usually serum markers like amylase, lipase, trypsinogen, and elastase, and even in cases of cancer, tumor markers like CA 19.19 is done. Then ultrasound, endoscopic ultrasound, CT scan, MRCP, and ERCP. So here we can see this is the CT scan of the abdomen. Here we can appreciate this is the pancreas, this is liver, and here is the aorta, and this one is the vertebral.
Ritika, are you discussing anatomy and surgical anatomy only, or you're discussing all investigations also?
Sir, सिर्फ last है investigation क्या क्या करनी है. Sir, that's it.
Because then everything will be repeated. There is no need for all this. Let the other fellow start it.
Okay, sir.
जी सर.
Sir, I've completed. Lalit sir.
आपका और कुछ बचा है?
नहीं sir, मेरा complete हो गया. Lalit sir.